So we're going to talk about osteoarthritis and its evidence-based management. So the first and the most important thing that we need to communicate to the patient is that osteoarthritis is not a disease. It is age-related wear and tear. बीमारी नहीं है. I have to rephrase this sentence in Urdu and in English so many times, almost daily. तो मुझे डर लगता है कि नींद में भी कभी कभार ऐसा ना बनूं कि ऑस्टियोआर्थराइटिस बीमारी नहीं है. But as a fact, so I mean to say कि if you say this to the patient, half of the problem is solved anyway. क्योंकि they are really scared of this. कि मुझे आर्थराइटिस हो गई है, बस अब तो मैं गया या गई काम से. So the first step in treatment is assuring the patient that it's not a disease. It's an age-related wear and tear, just like hair turns white, just like you've got freckles on your skin and you start to become weak. So then you can tell them that it not only involves the articular cartilage but also involves the bone and the synovium, and it is also present in the most developed countries in the first world. So in USA, for instance, we have over 20 million people who have been affected by arthritis who are more than 70 years of age. Or 80 to 90% of the people who are above 65 or 65 would have some radiographic features of osteoarthritis. So it's not something to worry, it's something that we need to understand and engage doctors and other individuals to get the life going. But there are, yes, some risk factors associated with it, which can increase the intensity of the problems associated with arthritis. So unfortunately, female sex, and if you have family history and if you have some malalignment of your weight-bearing bones like knees, it predisposes the patient to have early arthritis or more symptomatic arthritis because their alignment is not right. Plus, if you have had fractures involving the joints or the articular surface, then you are prone to have arthritis and its severity more than normal individuals. And then there is a category which is occupational or recreational overuse. So, for example, people who are labor class and have been involved in heavy labor in most of their lifetime, or sportsmen who are being in sportsmanship for quite some time, because of overuse, their articular cartilage kind of wear out rather quickly as compared to the other individuals. So there are some health effects related to osteoarthritis, and the first one that we need to appreciate is chronic pain, which is leading to depression. So general practitioners are right who are seeing most of these patients in their clinics, and they can tell most of these granddads and grandmoms who turn up in their clinic with knee pain, hip pain, shoulder pain, and wrist pain are kind of in a depressive personality because they have been having this pain for quite some time, and despite having heavy loaded medications, they are still in pain. So the depression side of the effect needs to be understood because that increases sympathy and relationship with the patient, which of course is important in treating the patient not only for arthritis but for any other problem. And then physical disability, because you have pain, so you have problem in activities of daily living, so much so that you can't stand up, you can't walk properly, you can't go to the toilet for loo, you can't go to the dining table. And also there is a risk of fall because you are struggling, standing, walking down the corridors, so you are more likely to tumble than any other individual. And plus the financial burden of management, even if you have a fall or you are heading towards surgical management. Sign and symptoms, I guess general practitioners and our colleagues who are listening would know already that arthritis is related to joint pain, reduced range of motion of the joint, sometimes painful crepitus, and also stiffness, which is actually the primary cause of difficulty in activities of daily living. So in diagnosis, what we need to do is, in addition to examining the joint, we need to exclude other causes of pain. Because if you do not exclude other causes of pain, then you can end up in a serious situation where you are labeling the pain as osteoarthritis, and maybe you are missing something which is absolutely important. So attention to exclusion of other causes of pain is important. Plus, always try to examine the joint above and the joint below. It's a simple rule which has been taught to the doctors from their medical school days, but we need to remind ourselves because we see a lot of patients in clinic and we sometimes tend to forget this rule, especially for the knee. So a lot of patients who have knee arthritis may have pain in the knee because of knee arthritis, but also have pain in the knee not because of the arthritis that is apparent on X-ray, but because of a problem in the hip. And elderly people can have arthritis in the hip, but can also have metastatic disease in the hip, can have some sort of fractures in the hip region. So it's very important to examine the joint above and joint below. And although it is rare to inflammatory arthritis in an elderly group of people, but it is always good to remember that. Plus, myalgia, which is a kind of syndrome situation where you have pain and aches everywhere. So that may need some kind of dedicated medical management rather than arthritis itself. And imaging is very simple. You can have plain X-rays and you can see that it is very clear once you have arthritis. Non-operative treatment. So, non-operative is, I would say, is the most important aspect of treating the patients with arthritis. But the problem is, it takes some time and it is a bit of a struggle on the doctor's behalf and on the patient behalf, because doctors don't have time to explain everything to the patient, and the patient usually tend to start using heavy dose medications, and they do not have an intention to treat themselves with non-operative medication either. So I think in our circumstances where people are suffering from financial challenges, if we kind of intensify and concentrate on non-operative modes of treatment, we can help our patients a lot. I'm saying this as a matter of fact, although being a surgeon myself, I'm very much inclined towards the operative management as well, but I think for educational purposes and also for treating the patients in all honesty, it is important to pay attention to the detail of non-operative management. And those include lifestyle modification, rehabilitation, physiotherapy, maybe braces or insoles, and then some kind of pharmaceutical management. Lifestyle modification takes a little bit of time for the patient to understand and for the doctor to explain. So if you tell these elderly individuals to avoid aggravating factors, including impact activities, stair climbing, including adjustment of the sitting height, including weight loss, and including some dietary arrangements. So a lot of pain and ache that these patients would have can. So if you avoid high heat cooked foods like barbecue type of stuff, then it can reduce acutely painful episodes in arthritic joints. Plus, diets rich in vitamin C can slow the progression of osteoarthritis. Then exercise and rehabilitation. Now, exercise and rehabilitation is one of the cornerstones of managing pain and reducing disability. But the problem is, our patients are less prone to doing exercise, plus we don't have the time to explain to them the exercise, and our physiotherapy people are not in close liaison with the treating physician to educate the patients about the correct exercises for an arthritic joint. If we can summarize, and the doctors can take a take-home message from this presentation about exercise for arthritis, then I would say that exercise, number one, should be done very slowly. Number two, it should be done repeatedly. And number three, it should not be against any resistance. And it should be within the tolerance level of the patient. Even simple range of motion exercise or quadriceps strengthening exercise, for example, in the knee, can reduce the pain and increase the walking confidence of the patient enormously. But the prerequisites are, again, doing it slowly and gradually, doing it repeatedly, and not against resistance. The problem with physiotherapy is that most of the time either they do passive range of motion and muscle strengthening exercise, they do not actually strengthen the muscles, or they do too much. For an arthritic joint, if you subject them to fast and repetitive exercise, they will do it for a while and then they will go away because it will increase the pain. So exercise and rehabilitation is absolutely important, and it helps a lot, provided it can be done correctly. So the bottom line is that it can manage osteoarthritis very effectively to the extent that patient might not need any treatment further. And even if the patient requires surgery as a last resort, surgery will be more successful because the patient will be able to do more after surgery if he has done some exercise before surgery. Now, the fairy tale stories, ultrasound, scans, acupuncture, hydrotherapy, thermotherapy, ice therapy, homeopathy, herbal medicine, a lot of these things are hanging around in our environment, and not only here, even in the developed world. And Arthritis Research Foundation UK did a lot of research on these things, and they have concluded that there is no scientific evidence for all of this. At the end of the day, they tend to control pain, just like a tablet Constant or a Voltrol or Arthrotex, for instance, will control pain. So they don't have any magic. Braces and orthotics, they were used fairly liberally around 10-15 years ago for arthritis management in the hip and in the knee, but I guess even in the environment of low financial cost healthcare system, there are no more use, not only because they are ineffective, but also because there are compliance issues and they are very difficult to use on a daily basis. Now this is something which is very interesting, but involves a lot of effort, which is the combined biopsychosocial approach. This is quite famous in Australia, and they believe that if you educate the patient about arthritis in detail, you can assess them regarding their functional requirements and function, their disability and their support system. You can educate them about diet, exercise and physical therapy, as we are just doing through the wonderful efforts of Team Pfizer, and you can engage them in some kind of weight reduction program. Then it will help a lot in terms of managing arthritis, because elderly population is everywhere. They're not only in Pakistan, they're actually more so in the Western world because of the advancing medical care. So the combined biopsychosocial component needs to be understood, at least if we can't imply that in our healthcare setting. Now, pharmacological treatment. I'll just whiz through the common pharmacological treatment, which are very famous all over the globe for their use in arthritis. Glucosamine chondroitin sulfate. Glucosamine chondroitin sulfate was the first line therapy in early 90s and late 90s. It was driven by the American pharmaceutical industry as a magical drug for osteoarthritis. Glucosamine and chondroitin sulfate are ingredients of articular cartilage, but what needs to be understood is that they are comprising less than 10 to 15% of the articular cartilage itself. If you look at the American Academy of Orthopedic Surgery website now, these days, there is a very clear statement that glucosamine and chondroitin sulfate is equal to placebo, and there is no role of glucosamine and chondroitin sulfate in arthritis treatment nowadays. It's quite amazing because the same website was promoting this as first-line treatment and medical treatment for arthritis. So in our setting, where people are suffering from financial challenges, we need to do in treating arthritis, and since there is no side effect, why should not they use it? So I tend to go in the middle somewhere where I tend to prescribe these medications to people who are having early or mild arthritis, give them this medication for about 3 months in optimal dose, and I clearly say to them that if they benefit, they can use it for a while, but if they don't, they need to stop it. So that's kind of a balanced approach rather than an approach on the right hand side or the left hand side. So you can do that. Then pain medications. The only message that I would like to give in terms of pain medication is that they're all pain medications and they should be started in a low, mild dosages because we don't know person to person response. Some people would just have a dramatic relief from paracetamol, and some people would have no relief even if you give them loads of high strength opioids and NSAIDs. So start with a low dose, see how it's going on, and always tell the patient that they are pain medications, they are not the treatment for arthritis. If you clarify this message, they will themselves hopefully cut off the medications because all of these medications have side effects. So I'm not going to go on every individual and single medication at the moment. Topical NSAIDs are relatively safer because they, at the end of the day, are not going to the system and they give you some kind of soothing effect on the joints involved. Then comes the turn of intra-articular injection. So again, intra-articular hyaluronic acid is kind of seen as an excitement in our culture and all around the globe. And there are very costly formulations available which cost about 40 to 50,000 rupees per injection for a year. And they are being recommended by our rheumatology colleagues or orthopedic surgeons who are not doing joint replacement surgeries, unfortunately. Again, their effectiveness is not really proven. They may work for a while, but they are not curing arthritis. So as long as you know the limitation and you educate the patient about their limitation, and you are doing them in a highly sterile environment so that you don't infect the joint, you can justify its limited use. Same is for corticosteroid injection. So if the patient is really struggling, is not a candidate for joint replacement therapy or joint replacement surgery, and you have exhausted all other treatment options as discussed before, then you can use it once or twice or at the most 3 times with an interval of 6 to 8 months for pain relief. But what is wrong is, and unfortunately still being practiced in our society, is that they tend to get injection every 6 weeks, every 3 months as a treatment. And I've seen a lot of these patients and have done a lot of arthroscopic washout as a result of infection because of corticosteroid and hyaluronic acid injections. Again, some fairy tales. As a matter of interest, there are complementary medicines available which people use, including turmeric, fish liver oil, devil's claw, Bangladesh, China, and whatnot. All of these, as scientifically researched by Arthritis Research UK, they don't have any effectiveness in treating arthritis except that they are breaking the pain cycles only. Now is the turn of some glamorous looking orthobiologic treatments in the treatment of arthritis. People are receiving them with a lot of excitement, including PRP and stem cell therapy. So to start off, these approaches have not yet achieved a sufficient scientific evidence base to warrant widespread clinical application. The problem is misinterpretation or hurried translation of new therapies into clinical practice as a result of poorly characterized and suboptimal research and clinical applications. The main problem is that the role of biologics has been oversimplified. People have animated videos and they will show you how beautifully the cartilage is restored, which unfortunately is not. So their use in clinical treatment needs to be exercised with extreme caution. PRP, platelet rich plasma. इसमें जो प्रॉब्लम है वो ये है कि प्लेटलेट रिच प्लाज्मा में क्या होता है, प्लेटलेट्स होते हैं और प्लेटलेट्स में क्या ऐसा, लेट मी से गिदड़ सिंगी है जो सब चीजें ठीक कर देगा. देयर इज नथिंग इन प्लेटलेट्स एक्सेप्ट सम इन्फ्लेमेटरी मीडिएटर्स, और we expect that those inflammatory mediators will just reverse the pain and the effects of osteoarthritis. I tell you what, these inflammatory mediators are about 39 to 41 in platelet-rich plasma, and if you investigate those inflammatory mediators, you will get to know very interestingly that they themselves have contradictory effects to each other. For the same reason, even in US, there are 17 different commercial protocols. Now, if you are trying to prepare a drug with 17 different commercial protocols, that in itself is defeating the purpose and inviting you to think that something is not right. So, 17 PRP के protocols है, 17 different compositions and characteristics, और उसका कोई clear cut role नहीं है, not only in arthritis but also in muscle, tendon and ligament injuries. तो इसको अच्छी तरह समझ लें. अब ये देखें, ये वेरिएबल्स हैं, ये सारी चीजें आपको देखनी होती हैं. एज, जेंडर, कोमोर्बिडिटीज, कंकरेंट मेडिकेशन, न्यूट्रिशनल स्टेटस, फिर प्रोसेसिंग के अंदर ब्लड कलेक्शन, स्टोरेज कंडीशन, स्किन प्रोटोकॉल, एक्टिवेशन प्रोटोकॉल. So unfortunately, because there is a lot of financial gimmicks involved in healthcare industry, so you will see a lot of people with different machines coming to the clinic and the hospital OPD area saying, we have spin protocol, this is fantastic, this is very, very good, and you start giving PRP at the cost of 40,000-50,000 an injection, and I tell you what, it's equal to nothing or maybe equal to intra-articular corticosteroid injections, which is about 1,000-2,000 rupees. तो अगर इंट्रा-आर्टिकुलर इंजेक्शन कोर्टिकोस्टेरॉइड का देके भी 3 महीने 6 हफ्ते और साल का फायदा हो सकता है, तो पीआरपी से भी इतना ही फायदा हो सकता है यार, और कोई एक्स्ट्रा फायदा नहीं है. So I would say to my colleagues, please, if you don't believe me, read about it yourself and try to get the truth, and then you will realize that we need to be careful. ये सारा कुछ मैं किस बेस पे कह रहा हूँ, randomized controlled trials की बेस पे कह रहा हूँ, ठीक है ना, which is level 1 evidence. It's not something the drug company has done for itself. It's randomized RCT, randomized controlled trial, and there are a lot of these available. So please go and read about it, and you will get to know what's going on. Then mesenchymal stem cells, ये भी एक बड़ा मसला है. इसको देखो, वो जी क्लिनिक खोल के बैठता है और कहते हैं स्टेम सेल जाएगा और वो जाके आर्टिकुलर कार्टिलेज बना देगा और आपका नहीं है पहले की हो जाएगा. Rubbish. It's not going to happen. Yes, stem cell is a pluripotent cell. It has got a lot of potential, but the problem is that if you inject a stem cell from whatever area of the body into the knee joint, you can inject it, you can get it and inject it again, but you cannot control and direct the stem cell to make articular cartilage or hyaline articular cartilage, which is what is inside your knee or inside your hip. So please try to understand that these therapies are still evolving, they are experimental, and I think it's unfair to our patients if we don't tell them their limitations and we keep injecting these things into their joints. Yes, there are some newer things which you can understand and which you can do it in outpatient setting if you read the anatomy, and those are genicular nerve blocks. Genicular nerve is the nerve which is essentially supplied to the knee, and they are running near the patella. So if you know the anatomy, then you can give them these nerve blocks and they can have good pain relief. So for patients who are not surgical candidates, who are kind of community bound, elderly people and have intense pain, you can inject them yourself or you can refer them to the specialist in our hospital or to me, and we can inject them for pain relief. इसका भी क्या है कि बिल्कुल क्लियर है कि जो नर्व सप्लाई जा रही है नी को उसको ब्लॉक कर दो तो पेन खत्म हो जाएगा कुछ अर्से के लिए. So as I said before, if we kind of educate the patient, if we tell them about the limitations of medications and injections, if we make them to exercise, if we educate them about avoid impact activity and reduce weight, a lot of patients would have substantial benefit enough not to come to the clinic of an orthopedic surgeon, for instance, for any kind of surgical intervention. But in all honesty, if you have done all of it and you know that the patient is suffering and you know that you have a facility available, then rather than injecting right and left with materials that are not good, I believe you should refer them to the specialist or the surgeon to have the correct treatment. So for surgical treatment of the knee arthritis, we have got proximal tibial osteotomy, arthroscopy, partial knee replacement, and total knee replacement. So for young active patients who are labor class and you've got one compartment disease, you can sort of alter the alignment of the joint and equalize the distribution on both medial and lateral side as evident in the picture, pre-operative and post-operative, and they can have good pain relief for quite some time. You can see at the picture at the bottom, there is a knee with medial arthritis predominantly and reduced joint space, and as a result of proximal tibial osteotomy, there is some resurgence of medial joint space and the lateral joint space is also open and there is pain relief. The problem with this operation is that it has inconsistent results and it's not an easy operation because you're breaking the bone, you're trying to align it correctly, which you may not be able to, and then you're at risk of having non-union at the site and also the risk of having repeat operation as a result of total knee replacement fairly soon. Then arthroscopy, well, some surgeons will offer arthroscopy, but in all honesty, arthroscopy has very limited role in knee arthritis or even hip arthritis because it can do nothing. Yes, if you have a degenerative there, it's giving you mechanical symptoms in terms of sharp pain and walking or giving way, or you have lupus, then arthroscopically you can cure the problem. It will reduce the mechanical problem but will not cure arthritis. Partial replacements are kind of a newer modality in treatment of arthritis because you can see here that only patellofemoral joint or only medial compartment can be replaced. The beauty of this operation is that you replace what is going out and you don't touch what is right, which kind of makes sense to the human mind, and it is very simple. तो भाई जो खराब है उसको ठीक कर दो, जो खराब नहीं है उसको मत छेड़ो, as compared to भाई थोड़ा सा खराब है तो पूरा joint ही बदल दो, which was the standard of treatment and is still standard of treatment in quite some parts of the world. But over here, reduce only what is reduced, and the beauty is कि आपने न ACL काटा, न PCL काटा, ligaments आपके अपने, तो joint आपका अपना है, तो joint की जो feeling है वो आपकी बरकरार रहती है, recovery बहुत fast है. You can essentially do a partial knee replacement a day case, with people walking in, having it done and going out in the evening, or at the most अगले दिन जा सकते हैं. तो recovery fast है, आपके joint की feeling अच्छी होती है, जिससे normally knee replacement के बाद आपको तकरीबन 6 हफ्ते 8 हफ्ते 9 महीने 3 महीने लग गए, क्योंकि elderly लोग होते हैं, एक kind of aggressive operation at total replacement. So you can actually get them quicker on feet with partial replacement. सिर्फ इसमें जो glitch है कि जो दूसरे ऑपरेट, लेकिन जो लिटरेचर में बताता है वो ये है कि इसका सर्वाइवल 10 years है, जो टोटल नी रिप्लेसमेंट का भी होता है. Why not to have a smaller operation rather than a bigger operation? But it needs to be clear if the patient is having only one compartment arthritis, and also clinical check करना पड़ता है कि उसी से प्रॉब्लम आ रही है, बच्चे किसी और जगह से नहीं आ रही. टोटल नी रिप्लेसमेंट इज अ गोल्ड स्टैंडर्ड. हमारे यहाँ ज़्यादा कॉमन इसलिए है कि लोगों को पार्शियल नी का पता नहीं है, या फिर वो आते ही बहुत देर से जब तीनों कंपार्टमेंट चले जाते हैं. तो इट्स अ गुड ऑपरेशन फॉर दोज पीपल, कैन हैव इट डन. 95% सर्वाइवल है 15 years में और 85% इम्प्लांट सर्वाइवल है 20 years. तो तकरीबन लाइफ टाइम ही है. अगर आप 65-70 years के एज में कराते हैं, you can get away with it till your age is 85 or 90, which is quite a bit. इसमें जो इम्पोर्टेंट है वो यही है कि जब मरीज चलता फिरता हो और उसको ज़्यादा कोमॉर्बिड ना हो तो उसी वक्त करा लें, बहुत ज़्यादा लेट करने से फायदा नहीं है। So this is an interesting slide where you can see how things have improved. हम बड़े फख्र से कहते हैं कि आईफोन का फलाना मॉडल आ गया, होंडा सिविक में ये फंक्शन आ गया। तो डॉक्टर्स कैन ऑल्सो टेल पेशेंट एंड सर्जन कैन ऑल्सो टेल पेशेंट भाई कि आईफोन और गाड़ियों के अलावा नी रिप्लेसमेंट और ऑपरेशन भी खासे एडवांस हो गए। सो यू कैन सी द ग्रीन बार इज टेलिंग यू द रिजल्ट्स ऑफ नी रिप्लेसमेंट इन द पीरियड ऑफ 1976 टू 1985, जब आपका साल के अंदर डिवीजन रेट 10% था ग्रीन बार में। अगर आप देखें हॉरिजॉन्टल बार में आपको ईयर्स आफ्टर इंडेक्स ऑपरेशन, अब 4 साल को अगर डॉट करें तो 4 साल में 10% नी रिप्लेस हुआ है। अब अगर आप देखें 2006 टू 2012 वाला, उसमें हार्डली 0.5% लोगों को रिवीजन की जरूरत पड़ती है, और ये प्रीटी मच सेम ही रहता है, यानी कि 16-18 साल में भी आपको 5% तक रिवीजन रहता है। इट इज फेयरली गुड। इसका मतलब है कि अगर आपने 100 लोगों का ऑपरेशन किया तो उनमें से 95-96 मरीज जो है वो तकरीबन 18 साल तक बिल्कुल ठीक रहेंगे, which is quite good. So things have evolved, the implants have changed, the surgeons have learned a lot, anesthesia अच्छा हो गया, हर चीज बदल गई है। तो हिप आर्थराइटिस में एक चीज है जो मैं आपको बताना चाहता हूँ, ये अर्ली आर्थराइटिस की वजूहत होती है। हिप का शेप थोड़ा सा डिफरेंट होता है, जिन लोगों को नहीं पता होता वो मरीज को यही कहते रहते हैं कि आप चले चले कुछ नहीं होगा, जबकि अब जो है हमें अंदाजा हो गया है कि हिप का शेप डिफरेंट अगर हो, कैम्प टाइप या पिंसर टाइप हिप जो नजर आ रहा है आपको, जिसमें एक बम्प बना हुआ है कैम्प टाइप में, और पिंसर में स्टेबलम का मार्जिन थोड़ा सा ओवर क्राउड कर रहा है हिप को, इन प्रॉब्लम्स को अगर आइडेंटिफाई किया जाए और अर्ली स्टेज पे आप भेजें उसको, तो आर्थ्रोस्कोपी के लिए आप देखें पिक्चर के अंदर नीचे हिप की आर्थ्रोस्कोपी भी कॉमन है। पहले लोग नी आर्थ्रोस्कोपी की बात करते थे, अब हिप की आर्थ्रोस्कोपी होती है, प्रैक्टिस एट यहाँ एज वेल। इसमें आप स्कोप डाल के एक्सरे में देख के जो थोड़ा सा बम्प है उसको साफ कर दें तो घंटे 1.5 घंटे के ऑपरेशन में आपका पूरा हिप बच जाता है। अदरवाइज दिस बम्प keeps on rubbing the articular cartilage and you can get arthritis at a rather younger age. This is one of the newer things that you need to know so that you can see it on X-ray, recognize it on X-ray, and then make an early referral to the specialist. दूसरा ये है कि अगर बहुत ग्रॉसली शेप मिसमैच हो तो आप उसके अंदर एसिटेबलम की ऑस्टियोटमी करके, सीकर की ऑस्टियोटमी करके हिप की कवरेज बढ़ा सकते हैं, उससे भी आप को बचा सकते हैं अपने नेटिव हिप को। ये भी कॉमन है। तो these things need to be understood, need to be appreciated, and need to be addressed on the right time by early referral to the specialist. फिर हिप की तरह जो है, नी की तरह यहाँ पर भी गोल्ड स्टैंडर्ड टोटल हिप रिप्लेसमेंट। इसमें जो चीज़ इम्पोर्टेंट है वो ये है कि पहले ये कंसेप्ट था कि 60-70 के हो जाए तब आप हिप रिप्लेसमेंट कराएं, इसलिए कि आपका हिप तो बड़ी जल्दी खत्म हो जाए। तो अब ऐसा नहीं है कि आप गॉट गुड मटीरियल, which is a ceramic, which you can see the thin articular surface of the newer hip. So ceramic on ceramic is a costly articular bearing surface, but it can survive up to 30-40 years. So you can do total hip replacement with disabling pain in younger individuals. So here is something to summarize. Before joint replacement surgery, it shows that the patient has been offered at least one core non-surgical treatment option in detail, जैसे मैंने आपको कहा. Consider joint replacement for people who experience severe pain affecting quality of life and have failed non-surgical treatment. एक बार पता हो जाए कि सारा कुछ बता दिया, समझा दिया कि कुछ कर भी नहीं हो रहा, तो फिर दाएं बाएं ट्रीटमेंट लेकर पीआरपी और स्टेम सेल और स्टेरॉइड इंजेक्शन लगाने के बजाय आप उसको आपके शहर में जो भी एक्सपर्ट सर्जन हैं जॉइंट रिप्लेसमेंट, उनकी तरफ आप भेज दें ताकि उनका अच्छा ट्रीटमेंट हो जाए और लाइफ स्टाइल बेहतर हो जाए। और ये जो इफेक्ट है कि एज, सेक्स, स्मोकिंग, ओबेसिटी, कोमॉर्बिडिटीज, इसका अगर आपके पास हॉस्पिटल के अंदर रोबस्ट सिस्टम हो एनेस्थेटिक असेसमेंट का, देन यू कैन गेट अवे विद द प्रॉब्लम ऑफ और चैलेंज ऑफ जॉइंट रिप्लेसमेंट। बट यस, वी हैव एथिकल, लीगल एंड मॉरल responsibility of informing patients about the benefits and risks of surgery and consequences of not having surgery, and also explaining to them the recovery and rehabilitation involved in surgery. तो आपको सिर्फ बताना चाहता हूँ आखिर में कि advancements are there frequent bilateral total knee replacements are done across everywhere, and we do it at our hand as well. And they are fantastic and wonderful operations with good results. तो आप देखें जो बहुत टेढ़े मेढ़े जॉइंट्स होते हैं सारे मेरे अपने पेशेंट्स के हैं, उनको भी हम नी रिप्लेसमेंट करते हैं और ये अल्लाह के फजल से बहुत अच्छे हो जाते हैं और उनको बहुत फायदा होता है. So we have also introduced this partial knee replacement at Yahan Hospital. ये हमारी पहली ऑपरेशन की पिक्चर है. हमारे साथ ग्रुप ऑफ टेक्नीशियंस हैं और इस पेशेंट को तकरीबन 3 साल हो गए. ये तो उनकी पिक्चर है पहले ऑपरेशन. शी माशाल्लाह डूइंग वेरी वेल विदाउट एनी प्रॉब्लम्स. एक ईयर छोटे से सर्जरी होती है और प्रॉब्लम रिजॉल्व हो जाता है. इसी तरह जो है ये रूमेटॉइड पेशेंट है, इसको जो है एडवांसमेंट की वजह से हमने एक नी और एक स्टेज में किया. राइट हैंड हिप आप यू कैन अप्रिशिएट द स्टेबलम इज गोइंग इनटू द पेल्विस. उसका हमने लेफ्ट साइड का नी किया, उसकी जो बोन कट्स थे वो स्टेबलम में मॉर्सलाइज करके बोन ग्राफ्ट के तौर पर डाल दिए. अगर आप उसका रिवाइज देखें ऊपर की 2 पिक्चर्स में जो राइट साइड की पिक्चर है तो पूरा गड़ा जो है उसको हमने नी के कट्स कर दिया. इसी तरह फिर वो अनफॉर्चुनेटली उसका दूसरी साइड का हिप यूज हो गया जो आपको पिक्चर में नजर आ रहा है. और राइट साइड का आप देखेंगे सारा गड़ा था तो पूरा ग्राफ्ट से भर गया, उसकी बोन रीस्टोर हो गई. यही चीज फिर हमने दूसरे साइड पे कर दी. इस हिप में हमने दूसरे साइड की नी ले ली, पेनफुल थी. तो कॉन्ट्रालैटरल हिप और नी 1 स्टेज में 2 साल के वक्त से किया. माशाल्लाह ही इज वॉकिंग वेरी वेल. ये वो पेशेंट है, वीडियो चल नहीं शायद. So we did 1 foot and 1 knee together and then later we did the other knee together. So about 4 years now on that. और फिर ये कि सिर्फ बायलैटरल नी साथ नहीं करते हैं, बायलैटरल हिप भी करते हैं कभी कभार. जैसे इस पेशेंट को था, उनके दोनों हिप्स आप देखें नेग्लेक्टेड डेवलपमेंटल डिस्प्लेज ऑफ द हिप था, डिसेबलिंग आर्थराइटिस की. आधे फेमरल हेड इसके डिस्टॉर्ट हो चुके हैं. हमने 1 स्टेज बायलैटरल टोटल हिप किया इनका. इसी तरह एक दूसरा पेशेंट था, इसके भी दोनों हिप्स खराब थे, इसकी दोनों हिप्स हमने एक साथ किए. उसके बाद ये बहुत चैलेंजिंग केस था, कोयटा से टीचर थी है और इनके दोनों हिप्स आप देखें बहुत हाई राइडिंग हिप्स थे. एंड शी वाज व्हीलचेयर बाउंड फॉर द लास्ट 3 to 4 years बिकॉज ऑफ इंक्रीजिंग पेन. बहुत अर्से तक चलाती रही, बिल्कुल अनबेरेबल पेन हो गया. और हमने दोनों इसके हिप्स किए. एंड शी माशाल्लाह अबाउट 4 years now from index operation and she is walking. So he is showing all this to you just to reassure you that there are operations available, there are surgical modalities available, which of course needs to be considered only if you have exhausted your non-operative options. तो अब और आगे चल के मल्टी मॉडल एनाल्जेसिया और क्विक रिहेबिलिटेशन प्रोटोकॉल्स की वजह से अर्ली डिस्चार्ज कैन बी डन और जेंडर स्पेसिफिक इम्प्लांट्स आ गए और ऑपरेशन को मजीद प्रिसाइज करने के लिए नेविगेटेड सिस्टम्स आ गए जिसमें हम कंप्यूटर से भी हेल्प लेते हैं अबाउट द प्रिसाइज प्लेसमेंट ऑफ द इम्प्लांट्स. सो लॉट इज गोइंग ऑन, अ लॉट ऑफ एक्साइटमेंट एंड अ लॉट ऑफ रीअश्योरेंस. थैंक यू वेरी मच.